Hello, and welcome to the symposium session, Intergenerational Decision-Making, the Role of Family Relationships in Medical Decision-Making. This symposium is organized by the Decision Sciences for Child Health Collaborative, which is the pediatric interest group of SNDM. My name is Sadia Sadiqzada. I'm a psychiatrist and clinician investigator in the Department of Psychiatry at St. Michael's Hospital and the University of Toronto. I'm also employed by Inner City Health Associates, where I provide psychiatric care to transitional aged youth at youth homeless shelters in Toronto. I recently completed my Science Master's in Health Policy and Management at the Harvard T.H. Chan School of Public Health. My research and clinical interests include early intervention in psychosis, transitional aged youth, and people experiencing homelessness. Today, I will be the moderator for today's presentation.
Hi, I'm so excited to be here today to talk about intergenerational decision-making, and particularly to focus for a few minutes on pediatric patients and their parents. I did have an institutional grant from Pfizer, but will not be talking about that work today. So those of you familiar with the shared decision-making literature know that there's a lot of discussion about the decision dyad, the healthcare provider and the adult patient. In pediatrics, we talk about the decision triad, that is a healthcare provider, a parent, and a child. But it gets complicated as the child could also be this age, and obviously the role in the decision varies based upon those differences. And also, just like in adults, there's a whole lot of other people that may be involved: a parent, grandparents, siblings, teachers, other healthcare providers. And so while the triad is the minimum, there may be a whole community involved in decision making. But frankly, while everyone agrees that a triad exists, most pediatric shared decision-making work focuses on the parent-provider dyad and pretty much ignores the role of the child. Today, I'm going to turn that on its head a little bit and talk about the parent-child dyad and their interactions in medical decision-making. Figuring out the appropriate balance between each measure of the triad, or in this case, the parent-child dyad, is tricky and varies with development. But you'll note that I haven't put age markers on this little figure because development doesn't necessarily correlate with age, despite legal statutes that make it seem like something magically happens at 14 or 16 or 18 or 21. In fact, the relative decision control of the parent and child probably varies over time and related to the specific decision. You may be very willing to have your child decide whether to take medication as a pill or a liquid, but less willing to let them decide whether to take medication at all. And that brings up the issue that I come at this from a shared decision-making framework, but there's another framework that's used frequently in pediatric decision research, and that was articulated by Victoria Miller and is the idea of decision-making involvement, which more explicitly acknowledges that the role of the child may not be equivalent to that of the parent or the healthcare provider. In either case, medical decision-making is a skill that needs to be fostered. We can't just assume that kids are going to develop this skill and know how to make decisions as they get older. And clinicians need to engage both the parent and the child to help in developing these skills. But it's complicated. Who's involved in the decision, as we saw in my earlier slide? Whose perspective is the truth? Gets to work that's much like that in other shared decision-making work, where we see that what we observe in shared decision-making is different than what healthcare providers or patients report. What's happening outside the visit? And I'm going to touch briefly on each of these issues, largely through the lens of my team's work, and then end with a few areas that are open for research. My goal today is to share questions more than provide answers. So in this study, we did semi-structured interviews with adolescents who either had inflammatory bowel disease or juvenile idiopathic arthritis. And we asked them to draw how decision-making occurred and then describe it. And in the top panel here, you see how this particular adolescent felt the decision occurred. And in the bottom, you see how this adolescent wished it had occurred. And what we learned in this study was that adolescents could articulate their roles in the decision-making, as well as the difference between what happened and what they wish happened. On the other hand, we also learned, perhaps not surprisingly, that there's no consistent role preference among adolescents. While this adolescent wished she had a larger role in the decision, others wished they had a smaller role, but everyone wanted to have some say. For this particular decision, a relatively high-risk medication called biologics for their chronic condition, adolescents identified specific roles for each person in the decision, which are shown here. unlike the distribution of decision-making control in the previous slide, here the adolescents were fairly consistent in describing the roles they wanted. You can see here the adolescent's role was to describe symptoms, discuss their preferences, or participate in decision-making. The parent was a researcher, a communicator, and a decision maker. And the clinician's role was to introduce the decision, provide information, and be the expert. And in fact, adolescents often articulated that they wanted the parents to defer more to the clinician's expertise, as they felt that the parents' research role sometimes led to slowing down the decision-making process. However, while these roles that were articulated were consistent within this sample about this decision, it turns out they are specific to the decision. In another study we did, we asked adolescents about decision-making roles for a very different decision, and that is starting testosterone for transgender male adolescents. And here you can see that the adolescent felt themselves to be a researcher and decision maker. They felt it was very important that they did the research about how the treatment would impact them. They described their parent as being a researcher, but having less of a decision-making role. And the clinician was an information source, but was not necessarily seen as an expert or as having a role in the decision. So we can see that understanding roles is really important, but we need to make sure that we understand the context in which these roles are being described and articulated. As I mentioned, in addition to the question of who's involved and what role do they have, another question is whose perspective represents the truth. And to some extent, this is more of a research conundrum than a clinical conundrum, because it evolves kind of naturally in the clinical environment, and a lot of this happens behind the scenes, and you may not realize the role that these different people are having in the decision. But here you can see, using the same sort of pie charts to look at how decision control happened in the decision. Again, this is the testosterone decision. Here the patient shows relatively equal, I would say, decision-making distribution amongst these 5 people, whereas the parent has it as unequal, and specifically adds in another person, the psychiatrist. So you can see there's a very different perspective on what happened, and this may have significant implications as you try and articulate the roles that individuals have and how they wish things happen. In some cases, we had patients who drew, in particular, who drew pictures that articulate people that parents had no idea were involved, such as friends or teachers. And while our group is focused on the bigger decisions, I do want to mention that the fact of the matter is that most medical decision-making involves the smaller decisions. Most illness management decisions are about treatment routines, activities, snacks, more than interactions with the healthcare system. And that it's really important that we think about these and work to help parents and adolescents build their decision-making skills in these smaller decisions so that adolescents and parents are ready to collaborate and give growing amounts of decision control to the adolescent in the bigger decisions that happen as well. So in this whirlwind, I think we've highlighted a few challenges that are both research and practical challenge. One is the whose truth is the truth. Whose perspective on the decision-making is the one that really represents a truth about decision-making. How do we weigh different goals and preferences? You know, when the parent wants one thing and the adolescent wants the other, it can be very tricky to figure out what the right decision is. How do we develop decision aids that engage parents and patients? Evidence suggests that children feel things are more fair and engage more if they're actively involved in the discussion, but most tools aren't structured for that. And finally, measurement. We really have a challenge in measuring shared decision-making overall, and particularly in pediatric decision-making. Other areas of pediatrics, such as quality of life measurement, have developed scales that are specific for children, adolescents, and parents, and we probably need that in decision-making as well if we really want to understand and give value to children and adolescent perspectives. So I thank you for your time, and I hope you'll come to the question part of the live portion of this symposium or reach out to me at another time. Thank you very much.
Hi, Ellen. Thank you so much for your presentation. I think a part that really stood out to me was the pie charts that the patients and their parents filled out. I loved that it was their original pie chart, so that was really fun to look at. I'm curious, in your experience, when we consider like the growing child or adolescent developmentally over time, have you noticed any particular trends in their perceived decision-making, so from a child onto adolescence? I'd imagine that over time, the adolescent may perceive themselves as more autonomous, or at least would wish to be.
Yeah, that's a great question. And I have to say, we haven't done the pie charts or really investigated the young children's thoughts and roles in their decision, though I think it's a really important area for work to be done. For the adolescents, there's not so much a desire to be more autonomous. It's more actually that as they get older, and these are still small samples, but as they get older and are less concrete thinkers, which would be appropriate developmentally, they're actually more interested in having help. So they see themselves more as the decision maker, but at the same time recognize that they want input from their parents and from healthcare providers, and also have more kind of focus or realization about the long-term impact of decision making. In the younger kids, we really see a very here and now approach to decision making. I want to feel better now. Who cares about what I'm going to feel like a month from now or a year from now? Whereas the older adolescents have a more fine-tuned ability to kind of think about both now and the future.
Ellen, in some of your work, when you're thinking about multiple people involved, is it possible to kind of separate out the sort of goals of the parents from the kind of goals of the kid? And if there's more than one person involved, or more than two people involved in decisions, there's going to be some sort of interweaving of people's desires. And if they're not all in concordance, which they can't always be in the world, as we've already heard, like how do we deal with that tension?
Yeah, welcome to pediatrics. But so some of our work has looked at how those preferences differ. And I think particularly our work in IBD showed some significant differences. I mentioned before how particularly the younger adolescents are very focused on the near term. And really the adolescents in that study, they wanted to feel better now. They wanted to defer to the physician's expertise because they wanted to feel better now. And they thought their parents should just kind of get over their concerns about their side effects. And so some of it in those instances in the coming together is just a matter of time. I think there are other ways, though. I think that when tools are developed to help facilitate decision making, they can be made in a way that helps people bring to light those differences. So our team's developed some tools kind of based on the Mayo's decision card model to look at decisions in IBD. And what we try and train the providers to do is to first ask the adolescent what matters to them in the decision, and then ask the parent, so that right away you're bringing to the forefront that the top thing, so consistent with what I said, the adolescents usually say that what they want to know is either how's the treatment going to be administered or how quickly will it work, whereas parents are much more likely to be concerned about side effects. And then we've designed the tool so that you can look at it side by side and they can start to have a discussion about that.
Thank you so much. What are the areas of measurement that you think are most needed?
So I think there's a couple areas. So one is that we need to have some measurement, and this is kind of my pipe dream, but I don't really know how we go about doing it, but we need to be able to look at all the relationships in the decision triad. And there is actually a measure that came out recently in the geriatric world looking at triadic decision making. But if I'm remembering correctly, it looked at the provider and the patient and the caregiver and the provider. But in this decision making, things are going every which way, right? So the parent and the kid are having some interactions, and the kid and the provider, and the parent and the provider. And so we need something that can really assess that complexity of decision making. And then the other is that there's a lot of measures that exist and are pretty good measures, either for measuring shared decision making or decision outcomes, decision conflict scale, decision regret, and none of it has been validated. Very little of it has been validated for parents answering about their kids, and none has been validated for adolescents, or let alone younger kids answering about themselves. And I think if we really want to understand kids' roles in decision making and how to improve and teach them to be involved in their medical decision making, we need to be able to measure it.
Thank you so much, Dr. Lipstein, for your presentation. Next, we have Robert and Gary Lynn Lindstrom. Robert and Gary Lynn both grew up in North Davis County and attended Davis High School. They married during college in 1988. During college, Gary Lynn worked as a dental assistant, while Robert worked on a Bachelor of Science in Mechanical Engineering, graduating in 1991. Also in 1991, they adopted their first child, Melissa. After college, they moved back to Davis County, where Robert worked on the Space Shuttle from 1991 to 2002, and Gary Lynn was a full-time mom and homemaker. During that time, they adopted their second child, Spencer, in 1996. Although unknown at birth, Spencer suffered from PMD leukodystrophy, a progressive degenerative disease, which caused his development to arrest around 4 to 6 months. In 2002, Robert went back to school and earned his law degree in 2004. In 2009, they adopted their third child, Eli. Today, Robert works for the Air Force and Gary Lynn works for the Church of Jesus Christ of Latter-day Saints. Melissa is 29, Spencer is 23, and Eli is 11. Spencer is nonverbal, non-weight-bearing, GJ tube fed, and is trach ventilator dependent.
So hello everybody, we're the Lundstroms. I'm Robert.
And I'm Gary Lynn.
And we're going to talk to you today about our son Spencer.
Spencer is 23, almost 24 years old, and has been diagnosed with PMD leukodystrophy. It's Polatzit-Schmerzbacher disease, and he's profoundly disabled and is non-weight-bearing, non-verbal, GJ tube fed, has a baclofen pump and trachea vent, so full care.
And we just have kind of a chronological list of events that have happened, decisions that we've made, that we can talk about. To kind of put some framework on this a little bit, context. Spencer, the diagnosis process for Spencer took about 8 years. And when we originally started, there weren't a lot of genetic tests and blood tests. Most of the diagnosis processes were clinical observation kind of stuff. And so we received the diagnosis when he was about 4 years old for Opitz FG syndrome. And he'd never really tracked very well with that diagnosis. And as the doctors kept working on it and as genetic testing came along, he was re-diagnosed with the leukodystrophy. And so those first 8 years, a lot of our decisions were made with the idea that he had this FG syndrome, which is not a complete arrest of development. It's a delay. Right. But most kids that have FG syndrome will continue to develop and develop those abilities that as they grow older. And that's where he never really tracked. He just was always way off the charts and was not developing. And so leukodystrophy was a much better diagnosis. But that really influenced our early decisions. So like one of the first things we had to decide was putting him on a G-tube. And at the time he had some surgery coming up. He was eating orally, but we were always struggling getting enough calories into him. And we feared that with the surgery, we would not be able to give him enough calories to sustain himself. So we decided at that time to do the G-tube placement. We had been talking about it for a long time, but had really been resistant to it because we had this idea, this belief that his development would continue to progress and we would outgrow the need for the G-tube. After the surgery, it became more and more evident that was never going to happen.
Yeah, and his motility was slow, and he wasn't weight, and we were using the G-tube for supplemental feeding, but it wasn't enough, and so we ended up doing G-tube all the time. And at that time, when we placed the G-tube, we did not do the Nissen. It was a couple years later. And when we were full-time feeding, we decided to do the Nissen because of his regurgitation and risk of aspiration. And then now it seems like a pretty insignificant decision, but back then it was a big decision for us.
And then when the spinal fusion surgery was coming up, and we've been talking about that for so long,
Because his scoliosis was
because his
increasing.
scoliosis was so bad that that we decided we needed to do the baclofen pump to try and help with that spasticity before that surgery. So,
And it had to be placed before the spinal fusion.
right. And so we made the decision to put the baclofen pump in, and immediately saw a total loss of tone in his extremities.
And I guess I didn't realize how much of his tone he was using to move. And I guess I didn't quite understand. And so it was quite a surprise when he ended up being kind of a little slug and he wasn't moving his arms at all.
Well, and honestly, post-op, you don't know what's, I mean, we probably were thinking that he was going to recover and get back to kind of where he was for several weeks after that. And it was probably 3 or 4 weeks down the road post-op that we were like, why is he not reaching anymore? Why is he not, raising his head anymore? And I don't know that the doctors, I don't think they had any expectation that that would happen. I don't know why it happened, but it did. And I guess we just have always held to the belief that reducing the spasticity, the benefit of reducing the spasticity outweighed long-term over the next 10, 15 years was going to outweigh the loss of that function. I don't know that that's accurate or not, but that's where we are today. So then after that, we went for many years without major problems or surgeries until he became very sick and developed a pneumonia. And we'd been really fortunate not to have pneumonias up to that point. This was when he was about 18 years old, so about 5 years ago. And he just continued to go downhill, and he finally crashed on us. That put us into the hospital, and that's when we made the trach vent decision. So Spencer had stopped smiling, and it was really hard to coax him out and get him to respond and smile and be verbal. And when he crashed, and we life flighted him to primary Pilgrims, and they intubated him.
And all the drugs they put on him, so he was, at first he had no responses anyway.
Right. But after a few days, while he was intubated, all of a sudden he started smiling at us.
We'd walk in the room and say his name, and he'd turn his head and have a big smile, and we were like, "Oh, he's back!"
I really think that was because he was not so focused on breathing that he could now, experience some of that enjoyment that he had before. And so, quality of life, that's what we were looking at. And so in a way, at that point, it became kind of an easy decision for us. It was quite dramatic, not traumatic, but dramatic in the way that we approached it, I suppose. But we got there, and the whole team of doctors was in agreement. That everybody saw the change in him. All his doctors that had worked with him previously and then saw him intubated were like, "Wow, this is like the old Spencer's back again." And so it really that really helped us come over the edge on that, and make that decision at that time. Now, so Spencer went from 3 or 4 hour a day kid to a 20-hour a day kid. I mean, you're constantly attending to the trach and the vent. He's not able to do any of that himself, and so we have him on alarms and monitors, and we continually go in and do suctioning, do the respiratory therapy, which is about a 2-hour process every time, three times a day.
3 times a day, yeah. So 6 hours a day is that. But we also had better access. And so in some ways it was easier, and we were struggling for years before that trying to keep him healthy and keep his lungs healthy. And so it's a trade-off, but I feel like we actually managed that trade-off pretty well. And after the trach event, we have nurses a lot now who help us, and we're so grateful for that. But we have to have eyes on him all the time now. And that's a big shift in your whole family life, big shift.
And that sort of leads into what our philosophy has been as we've approached all of these decisions with Spencer, which is we're kind of very conservative, and we take more of a wait and see approach, and then maybe wait until he has to have something done before we actually do it. And I think that's had some benefits to Spencer. Having him be able to function on his own for as long as he can, I think has kept his quality of life and health higher. And so that's been one of the indicators that we've looked at is, do we have to do this now? Can we wait? What are and making sure that we understand all the consequences of what we're about to do. And then the second thing that we look at is quality of life. And everything that we do for Spencer is gauged off of his ability to smile and laugh, because it's really the only thing that we have to communicate with him. He doesn't have any kind of affirmative communication methodology or any sort of system. He laughs and he cries. And so we always try and look at, are we going to get more smiles after doing this or less smiles? And so that's a big thing. Is it going to maintain his quality of life that he has currently? Is it going to improve his quality of life? And in the long run, will it give us better quality of life for a longer period of time? And so those are the questions we ask ourselves and as we try and make these decisions.
And also, I feel like we have surrounded ourselves with a great team of doctors, and we do rely upon their opinions. We don't always agree, they don't always agree, but we do rely upon them as sounding boards and information, and that has helped us to, I feel, make the decisions we needed to make when we needed to make them.
You alluded, Robert, to your philosophy changing over time in the decision-making of your son. I was wondering if you and Gary Lynn can tell us more about that.
So we started with an incorrect diagnosis. All of the early decisions, the G-tube placement, some of the surgeries that we did were really done under the idea that we would be able to resolve issues, or they would resolve over time as he grew and developed, when in reality, that was not going to happen. And so our methodology then changed less from, are we going to do things that are going to correct and improve his life as much as are we going to do things that are going to help him maintain a quality of life for a longer period of time, and so more therapeutic in nature as opposed to improvement related.
And I think too, we would try to let him accomplish as much as he could accomplish until we would make a significant intervention. So like feeding, for instance, even though we put the GJ tube in, we continued to feed him while he could do it. Orally also. But then when it became too significant of a risk for aspiration, we then, at least we still had that G tube and could go back to that, and it became full-time feeds. But we tried to let him guide us too, as to what his body could handle and what he then could not handle at this given time. So we had to then change our thinking and move to more, maybe more severe things, that we would have to do. So we kind of also tried to listen to, or not listen, but to watch how he was reacting and how he was accomplishing things.
I'm wondering if you guys could reflect on your experience in decision making and how kind of the experience of decision making has changed over time. Particularly as I'm thinking about it, I imagine that when Spencer was very young, although he had delays, decision making in some ways wasn't that different than making a decision for a more typically developing infant. Whereas I'm wondering if that experience of decision making felt different as the discrepancies between his abilities and his peers increased over time.
So I think that I think you're correct, with the exception of the seriousness of the decisions we were making. I don't think that the process was any different in feeding our normal healthy 2-year-old than feeding Spencer, except for the fact that now we were going to punch a hole in his stomach to do that. And so that, there's a whole level of seriousness that becomes involved in very simple decisions at that point. But over time, as his ability has dropped farther and farther off, and even because his condition is degenerative, even decreased over time, what I find is there's less input from Spencer to the degree that he can even provide it. Now it's almost non-existent, to where we have to, make the decision entirely on our own for what we think Spencer's desires, wishes, wants, and best interest are. And I think that that's been a very difficult thing as we're coming into the end of life kinds of decisions that we have to make. Is the process that much different? Maybe not, but the decisions themselves are hugely different.
So Robert and Gary Lynn, thank you so much. Seriously, we really appreciate you for joining us and sharing your very personal story about your lives and the life of your son, Spencer. Next, we have Dr. Jin Tae, who is an assistant professor in the College of Nursing at the University of Utah and a subject matter expert for the Hospice and Palliative Nurses Association's Advanced Care Planning Task Force. Her research interests center around patient and caregiver collaboration and communication in decision-making during serious illness. Dr. Tae's research benefits from her own experience within the field of home health nursing.
Hello everyone, my name is Jin Tae and I'm an assistant professor at the University of Utah's College of Nursing, and I'm presenting my study that was developed for my dissertation that looked at shared decision-making intervention between older adult home health patients and their caregivers. And here are my collaborators. I do not have any financial conflicts of interest to disclose. I'd like to acknowledge the funding I received from the University of Utah, and also like to point out that this study has been published in the Journal of Palliative Medicine. So when we think about advanced care planning, we usually think of older adults, and we also usually think about serious illness. However, advanced care planning is really applicable for everybody across all ages. The benefits, of course, are going to be more obvious at the end of life. So we do know that with patients, there's better quality at the end of life, as well as more preference concordant care. As well as for caregivers, there's decisional making benefits, satisfaction with care, and also bereavement outcomes associated with engaging in advanced care planning with patients. However, very few studies have really focused on shared decision-making for advanced care planning between the patient and the caregiver. Usually we think of shared decision-making in the context of patients and providers. Here are a handful of studies that have looked at the dyad between the patient and the caregiver. And you can see most of these studies actually present a form of intervention to both patients and the caregivers, either separately and then have them come together and discuss advanced directives together, or they just deliver the intervention to the dyad, really focusing on values clarification and providing some education. I would like to point out the studies by Song et al., which is about the spirit intervention, which is one of the more well-known dyadic interventions, where they really started to look into the thoughts and feelings that patients and their surrogates had regarding these end-of-life decisions. And we do see that they had this, they had improvements in perceived quality of communication, in decisional congruence, surrogate confidence, and also, but not decisional conflict. But this really moves into the area of not just having done it, but how advanced care planning is being done between the patient and the caregiver that might have an important consideration for these interventions. So I want to introduce the home health patient population, which is a more medically complex population with higher medical utilization. Despite all of this, they do have lower rates of advanced care planning when compared to other patients in long-term care settings, such as nursing homes and hospice. And they also have a higher degree of dependence on caregiving. So this makes them a really good population to think about when it comes to advanced care planning. And so I developed a collaboration-focused advanced care planning intervention using principles from the developmental contextual model of dyadic coping. And it consisted of a clinical vignette where the patient was supposedly really sick in the hospital and needed some decisions to be made for continuation or withdrawal of life-sustaining treatment. And caregivers were asked to think about themselves having to make this decision. They were then asked to talk to each other regarding their previous decision-making together as a team, and then also their thoughts and feelings for each other pertaining to this clinical vignette. Then they're asked to engage in a collaborative activity where they take 5 minutes to complete an advance directive together, just a page for 5 minutes. And this is without any help from the interventionist. So this was a one-group pre-post test study, and eligible patients were 55 years and older with at least a chronic condition. You can see that patients were in the age range of 68, that was the mean. And then caregivers were slightly younger with a mean age of 61. Majority of them were female, and about half of them were married to each other. So these were spousal dyads. Quite a number of emergency department visits and inpatient stays in the last 12 months, which is quite consistent with the home health patient population. I recruited 18 dyads, which it's altogether 36 participants to be in this study. And we examined the outcomes of the intervention on perceptions of collaboration, decisional conflict, and concordance in decision-making, as well as readiness for advanced care planning. So what we did find was that post-test, decisional conflict for patients and caregivers improved. For patients, it was in the subscale of uncertainty, whereas in caregivers, it was in the subscale of effective decision-making. And also for artificial nutrition and hydration, agreement at post-test increased by 27.7%. We are also starting to examine, this is a paper under review where presented the results of the video recorded interventional component part of the study, and looked at 3 topic domains: decisional topics, relational topics, and existential topics formed the 3 main topics that were discussed during their conversations. And as well as looking at whether these topics were negative or positive. So we did find that although there are a lot of similarities, there were some that were specific to caregivers and there were some that were specific to patients. And then finally, this is an analysis that is in progress where we looked at the perceptions of collaboration scale, we looked at some of the subscales, as well as uncertainty, and we did find some actor-partner effects with interpersonal enjoyment in collaboration, as well as decisional uncertainty. And I'd like to acknowledge Dr. Jiawen Guo, who has been pivotal in analyzing this. And so what are the implications of this research? So we really want to address the goals of the National Academies of Medicine, where we're really hoping to have patient-centered, family-oriented end-of-life care. And so including family members is important in, as a stakeholder in decisions. And it can provide benefits for patients as well as the caregiver, and really thinking about not having just done an advanced directive or having just participated in an intervention, but how it's being delivered, the communication quality, and as well as the acknowledgement that relational and emotional concerns are important for patients and caregivers. This has implications for quality of care and patient and family satisfaction. So I'd like to present my references at the end of the slide. And thank you for your time.
Thank you, Jen. I was also wondering, how does the deciding together intervention differ from the other dyadic advanced care planning interventions?
Yes, it was an advanced care planning intervention, but the focus of it was to enhance the collaborative decision-making aspect about, like, it's not just the patient's decision to do this type of life-sustaining treatment if I couldn't speak for myself, but it was a we decision, like what we were talking about, where it's not just this decision, even though the caregiver had to make it on behalf of the patient, the caregiver also has consequences from that decision, right? If the person, if the patient were to survive that procedure, for example, but have lasting deficits.
So in my profession, I do a little advanced care planning as well. And one thing that I have run into is an intimidation factor by group decisions. Mm-hmm. And there are occasions where the person who I'm writing paper for really doesn't want something to happen or has changed their mind. But because of the collaborative decision that was made earlier, they don't feel like they can express, that opinion any longer. So have you done any research in that area and how you can address, when someone changes their mind? Because much advanced care planning is not set in concrete. And these discussions, I recommend to my clients, you do this all the time. This is not a one-time thing and everything is decided and that's how you go forward. This is an ongoing evolutionary discussion. And so these kinds of things hopefully can get brought out, but I've seen it happen over and over again where someone doesn't want to rock the boat, so to speak.
That whole process is really important. And I think a lot more work has to be done on how people can navigate this process, because it's easy to say, you guys talk it over, but then we know those conversations don't happen. They're also very awkward to start. And then that topic of coercion, like, how can, I think in this regard, like what Ellen talked about with measurement, I think that's a really important thing to think about. Like, we need more tools to be able to assess if people are at risk for being, overridden in terms of like there's what say they have in the decision. There's one part of my study that's qualitative and that I'm still working on writing up, but part of that framework that I use, the theoretical framework, looks at different types of styles. So there are like 4 main styles according to the theory. There's the collaborative, and then the supportive, which we think of as positive, but then there's also uninvolved, and there's also controlling. So those are the things that we want to think about a little bit more.
Thank you, Dr. Tay, for your wonderful presentation. Next, we have Eve Wittenberg. Eve Wittenberg is a senior research scientist at Harvard T.H. Chan School of Public Health. She studies methods for measuring patient-relevant outcomes, including quality of life, preferences, and economic utilities, and the integration of these measures into decision analysis. Her work also encompasses the psychology of decision-making and the influence of psychology on the perception and articulation of outcomes.
Hi, I'm Eve Wittenberg. I'm from the Harvard School of Public Health, and I'm speaking with you from my home outside of Boston in Massachusetts. What we've heard so far in this session is that decision-making is a bigger process than just an individual. It involves people in the family across generations. So when a child is ill, the parents are involved in decision-making. And similarly, when an adult is ill, there may be a spouse involved in decision-making. There may be an adult child involved in decision-making. And even in some cases, there are people who are not actively involved in the decision, but they are in the mind of the person who's making the decision. So they're indirectly involved. So decision-making really is a larger process than just an individual. And in order to acknowledge this and to incorporate it into our decision analyses, we need to think more broadly than just the individual when we're thinking about our analyses, and specifically when we're thinking about economic evaluation. The second panel on cost effectiveness in health and medicine acknowledged that both costs and benefits that extend beyond the individual should be included in our evaluations and in our cost effectiveness analyses. So including costs that extend beyond the individual are somewhat more straightforward than including the benefits. These benefits are what we're talking about when we speak about spillover effects. And that is the idea that an illness, the effect of an illness, spills over to people around them. And that can happen in two different ways. One is that people who are caregivers, family caregivers, have a direct effect, a spillover effect on them by virtue of the caregiving that they provide. The other type of spillover effect is the caring about someone. So that is what happens to someone when there is someone close to them who is ill or who has some sort of health condition. That is things like anxiety and depression and stress and worry. All those things happen even when direct caregiving is not involved. In both these cases, it's been documented that there are measurable health effects on those individuals who are surrounding the person who we'll call the patient. And those health effects can range from, as I said, stress, anxiety, depression, fatigue, headaches, sleep problems, all the way up to exacerbation of existing health conditions. And there's also been documented mortality effects of people who are spouses, whose spouses are ill. So there's an increased risk of mortality in that sort of situation. There's also a documented increased risk of mortality among parents of some children who have health conditions. So there's really a wide array of effects that can accrue to people who are surrounding an individual who's ill. So the question is, how do we measure and how do we capture these spillover effects to include them in our analyses? There's a number of ways to think about it. If we're talking about health effects, well, we can measure them using health-related quality of life, as we do for an individual who has a particular type of illness. And we know how to do that using the measures that we have for health utility. Those can then be made into quality-adjusted life years or QALYs, and we can use them in cost-effectiveness analysis. When we start talking about these other effects that extend beyond health, that are what we call care-related quality of life, those are things that we don't capture in health-related quality of life. Those are things like the financial effects of having someone in the family who is ill, like the effects on social interactions when one is a caregiver, that those are diminished or constrained. There are also the positive effects from caregiving that are things like fulfillment and improved relationships with the individual who's ill. That bucket of things is what we call care-related quality of life. And there are some measures that have been developed to capture that. One is the carer qual, Another is the carer experience scale. And both of these have preference weights that have been measured. So we can put these into an economic evaluation, but the thing is they are somewhat different than health-related quality of life. So they don't come to QALYs. They are a different kind of measure, and we cannot combine them with QALYs. So work is ongoing to try to develop methods to combine care-related quality of life and health-related quality of life, so we could include both in an economic evaluation. And that should be forthcoming soon, and it's an area of additional research for us to move forward in this particular direction. But there are other things, even beyond care-related quality of life, that have been documented among people who are family members of individuals who are ill. And those are things like effects on employment, effects on education. These are other aspects of spillover effects that go beyond health-related quality of life and go beyond care-related quality of life. And we don't yet have ways to incorporate those into economic evaluation. So there's a couple of things I want to leave you with. One is that decision-making extends beyond an individual to include family members, caregivers, and non-caregiving family members across generations. So across children to parents to grandparents, and sort of horizontally, siblings, aunts and uncles. There is a big network of people who are included in decision-making to various degrees. And therefore, there is a big network of people who should be included in our economic evaluation, again, to varying degrees. And we haven't yet come to an agreement on to what degree those other people should be included and how many of them and what aspects of those effects we should include, essentially where we should draw the line around effects and around people. So those are areas for additional research, but I'll leave you with the idea that illness really does affect people beyond an individual. Those other people are included, in decision-making, and therefore should be included in our economic evaluations.
Hi, Eve. Thank you so much for your presentation. I guess to start off the conversation, I was wondering, how can we include spillover effects in cost-effectiveness analyses now as methods evolve?
Right. So that's one of our big challenges. And I think what's been so valuable about all of the talks that we've had so far is it's really highlighted how many other roles there are and how many sort of qualitatively different roles there are. So unfortunately, it only gets more complicated as you involve more people, because there are more people to consider, and there's kind of the contribution of each one to consider. We have some tools that currently exist that can measure outcomes for caregivers, but they're specifically about caregivers. And what we're hearing is that there are a lot of other people besides caregivers who don't necessarily do the day-to-day. The Lundstroms have really articulated well and given us a good feel for all the day-to-day care, but there's other people involved, and they even mentioned their other child. If we really want to pull in all these effects, we actually at this point need better instruments and better metrics to capture those other things and to start putting them into our cost effectiveness evaluations. A few things are on the horizon in terms of putting these in, and some of the ideas out there are weighting them somewhat differently. So perhaps we weight caregiver outcomes a little bit less compared to patient outcomes, and we acknowledge that the patient is our focus. But I don't think we're at the point yet of really being having any sort of consensus about how we should do that and whether they should be weighted.
I was wondering, Eve, what are the ethics of who is included in family spillover effects?
The ethics get pretty complicated pretty fast. So some of it is normative judgment about what we feel is important. And at the end of the day, a lot of our work in preferences really does come down to what we think is important and what we value, because that's inherently what we're doing. I think that some of the primary questions that are on the table right now involve how many people should we sort of include when we talk about spillover. So we are pretty much in agreement we should include a caregiver, but what about the other parent, or what about when caregiving is shared? And as I just mentioned, what about siblings? What about those other people who are involved? And how does it change if we have big families versus small families? Are we sort of giving more weight or more importance to the big ones versus the small ones? So again, a lot of these questions are still being kind of teased out and figured out, but I think the primary message is we need to start including some of this stuff. So we need to start sort of scratching away at this and then look at what it means when we include more, and then come to some sort of agreement about whether that is something we ethically want to do.
I was kind of thinking this is particularly relevant for Robert and Gary Lynn. I was wondering if you had any thoughts, especially on some of the things that you just spoke about in terms of it's not just parents, there are siblings, there can be other family members involved, in terms of spillover effects or the effects on caregivers. So just wondering what your thoughts were, if you have anything to add or to ask.
I'm looking at this question in both directions, both back toward my children, but also we were recently the primary caregivers for my parents as they went through their end of life. And so from a child perspective or a sibling perspective, the question is much more efficacious for me, because there were other siblings who were not as involved or even very involved, who would show up and all of a sudden have an opinion. And it was very difficult to do anything but smile and nod, because they just weren't involved in day-to-day care. They weren't involved in, even at a monthly level. Now, if I look back toward my children, one is older than Spencer, the other is significantly younger than Spencer. Even the child who's older than Spencer, really, we have talked to her about the decisions we make, but I'm not sure we've ever gone out of our way to say, well, what do you think we should do? And looking back now in hindsight, that for her, I think that would have been very important to do, and I don't think we did a very good job of that.
We were just trying to manage things, and do the best we could. I feel actually like our older daughter when Spencer got older and she was older, I did pull her aside and talk to her and say, what do you think about this? And what would you do? And sometimes I was surprised by her answers, because when we were faced doing the trach or not doing the trach, she was a little concerned about how he was going to come out of that, and if it would be better to not do it and let him go. And it was a difficult decision, but I was surprised by her emotion in it, and I'm glad I had that conversation with her. But ultimately, she wanted him to be around and be part of our family, and that's what we decided. So, sorry.
Thank you both. No, there's no reason to apologize. Thank you both so much for sharing such a rich and powerful, it really kind of adds color to, the academic side of the discussion, hearing the more personal side. So thank you so much for sharing that. I wanted to turn to Eve. Yeah, go ahead. Eve.
In response, what I think is, so Sadia, what you raised was the question of sort of the ethics around this. And yeah, we can study it forever. It's a very personal decision who's involved. And I think what this says to me, if I sit back with my researcher sort of scholarly hat on, is maybe there is not kind of a normative generalization for who's involved. And maybe this is one of those situations, like so many others, where it is just completely different across families. And it's going to differ for different siblings within a family. It's going to differ whether we're talking sort of like upwards, like us with our parents, or us with our children. There are so many dimensions to this that it's very unsatisfying as a researcher, because we want to answer that question that you posed, like what are the ethics and how does it all work out? It doesn't, and it's really messy. And we need to acknowledge that heterogeneity in the dynamics and therefore figure out the far more complex question of who do we include and how do we count things and how do we deal with the fact that there are probably, you know, so many different permutations of it. It's not going to have a neat and tidy answer, which nobody wants to hear.
But at least it'll keep us all asking questions for a long time.
We will now move on to the live Q&A session.
Hello, everyone, and welcome to the panel. Thank you so much. We assume that you have already watched the recording that we did earlier, I guess, not earlier this month, back in September, with many thanks to Jody. And so assuming that everyone's watched the video, I'm not going to go and repeat bios again. We will just launch right into the Q&A. A couple of things just to mention in terms of housekeeping. For those who are not familiar with Zoom, you can either choose to do gallery mode or you can choose to use speaker view so that the person who is speaking will pop up on a big screen in front of you. So if you're using speaker mode, I should be a big screen for you, my face on the big screen. I want to start off by thanking Jody and Daveen for inviting me to moderate today's panel. We're coming from a place of respect and dignity, and so we should keep that in mind when we're asking our questions today, especially keeping in mind that we have a family here present today, the Lundstroms, who have very kindly volunteered their time to talk about their own experiences as caregivers and family members. I encourage you all to, how things are going to go down is I'm going to encourage you all to please type in your questions within the chat box. And in lieu of just directly reading the question, I think it'd be a lot more fun if I can call upon the individual who asked the question to go ahead, unmute themselves and introduce yourself, tell us where you're speaking from, and then go ahead and ask your question. So I don't see any questions yet, so I'll give you some time to think about what you'd like to ask the panel. I'll start off with a couple of thoughts. So this is directed to Ellen. It's not so much a question, but more so a reflection. So as a psychiatrist involved in curriculum here at the University of Toronto, I put together a teaching session, a half day last Tuesday on gender affirming therapy for the general psychiatrist. And I actually included someone who identified as non-binary and as a person of color to speak to their experience. And so I definitely was inspired by your specific research on people who are gender nonconforming or those who are gender transitioning. So I just wanted to say thank you so much for putting together, for being involved in this session. It definitely inspired me to include people, not so much family members, because it wasn't necessarily my family member, but it was a friend of mine who identified as non-binary, and it was really cool to have them come and participate.
I'll just add, I think it's, you know, I think that field, particularly for gender transitioning youth who are seeking treatment, is a great example of a place that we really need family involvement, and that wouldn't traditionally have been considered necessarily amenable to shared decision-making interventions, because the data is really lousy because we just haven't been doing it very long. And so I'm really excited that it's hopefully inspired other people as well, and can help us think about how we do it, how we share decisions with family members, and how we share decisions when there's really limited data.
Absolutely. Thank you so much. So I have one question coming in from Darren. May I please ask Darren to go ahead, unmute yourself, and tell us where you're speaking from, and go ahead and ask your question.
Hi, everyone. This is Darren Zoronic from University of Michigan. Although my background looks like Hawaii, I'm actually in my basement. But this is a question, I guess, primarily for Dr. Tay. And this relates to kind of outcome measurement when we're thinking about improving these decisions, particularly when you're thinking about the end of life or advanced care planning context. Right? We have multiple players. We have the patient and the family member. And, it just doesn't seem like the existing outcome measures are enough, right? A lot of the studies you looked at mentioned decision conflict and regret, which just don't seem adequate to me to capture some of these things. Looking at other things that have been in other decisions, concordance with prior statements is also a challenge because of the fact that we know that people change their mind over time. So I'm just curious, if you or others have thoughts on, what are the best outcome measures and how do we move this field forward?
That's a great question, Darren, and I'm glad that you're interested in this area too. You are right, it is very limited, and these are the measures: decisional conflict, decisional regret, concordance have been measured over and over again. So that is really something that that could be expanded on, but I think that there are some out there that do get at the process. So Dr. Sudor's work, probably are familiar, and she has a pretty good instrument available for measuring the spectrum of the process of advanced care planning. So thinking along the lines of being ready and how engaged they are already in the process. So that is pretty interesting. And then there's also others that look at more hypothetical scenarios. And I think those are always a limitation, and I kind of steered away from those because in my study, at least, I wasn't looking at one particular disease group. And so that's kind of why I had to sort of develop this approach of asking those responses. And I think that there should be a broader discussion on what's important at the end of life. I think there is a scale called the Perspectives of Death and Dying, and that kind of looks at like whether a person values having a spiritual leader at in the last 7 days of life, that sort of thing. And that, I think, is a more holistic kind of way of looking at what's important to individuals and families. And these are actually quite different from even within the family unit, right? As we learned, Ellen's Dr. Lipstein's segment where she showed that pie chart. I think that was really interesting how it could be different even among a person's trajectory. So these things change. And so, yeah, that's a great question. And I hope I addressed it well.
Thank you so much, Jen. Did anyone else from the panel want to add to that?
I can just comment that we've done some work looking at decision-making trajectories, which is, gets a little bit at how this process changes and things change over time. But I totally agree that the measure limitations have been a real challenge. Our work was qualitative and looked at how decisions happen. And so we need ways to look, so using measures longitudinally can help, which is really not done very often, but also just figuring out what kind of the normative trajectory is and what the variation is so that we can help people kind of follow that path, whether it's end of life decision making or treatment decision making. I think it's kind of a similar challenge.
All right, thank you so much. Eve, did you want to add to that? Okay, for some reason you came up in speaker mode for me. Okay, so once again, just want to remind all to please, I encourage you to ask questions in the chat box because that allows for a livelier discussion. I'm just going to take a moment to look at some of the questions that I had prepared. One question actually I had for Eve that I don't think I asked you within the recording was that are there any measurement tools relevant for different age groups that you would like to speak to?
This is one of the challenges in the field when we're thinking about spillover effects, that the measures overall are emerging. To be delicate about it, we really don't have anything, just to be blunt, that can look at spillover across different age groups. We know quite well how it differs, how much it differs, and how these interactions are different and how the relationships are different. But honestly, we're just not at that stage. We're still at the stage of using health-related quality of life measures, for which we know there are some differences across ages, but those are still pretty crude at that time. So it's an area that we need to know more. But I think the more pressing issue is how much getting into the minutia of measurement is going to affect how our decisions are different. So in other words, it might be quite fine to have a cruder measure if what we really are looking at is how to incorporate other people's outcomes into decision making, than to focus our efforts on the real precision of the differences from the age group and the relationship and that kind of thing. We know those things exist, and really we just want to chunk this stuff in somehow at this point, and probably not perseverate on the precision of those differences.
Thank you so much, Eve. And I also want to say I'm loving the Halloween themed background you have there. Did anyone else in the panel want to add to that? If not, I have another question from the audience. So Nicole, may I please ask you to introduce yourself and where you're speaking from, and go ahead and ask your question.
Sure. Hi, everybody. This is Nicole Fowler from Indiana University in the Center for Aging Research. My area is medical decision-making for the triad when the older adult involved has some degree of cognitive impairment, and then a family caregiver is involved in the decision. And it's oftentimes this sort of balance of not just sort of caregiver emotion, but actual implications for the caregiver on the decision making, because they may be the ones who are kind of implementing the decision or sort of carrying through what the person's wishes are. And so sometimes trying to both honor the individual patient's desire, but also hear what the caregiver's concerns are about their ability to really act on that. And I'm curious what people's experiences are when that type of triad, which isn't all that different really from, I think, parental and children decision making, when parents are actively involved in that. So I'm curious to hear what the panelists have to say about that. Thanks.
I'll take a stab at responding. So I do agree, and I think this was also brought up, a great point brought up by Robert, that, you know, how can we kind of like make sure that the best interests are really the best interests of the patient, right? Because I think in end of life, especially, we tend to default to the patient's wishes as the kind of like the guiding philosophy, right? As people are making decisions. And so I think that weighting of the idea that Eve, Dr. Wittenberg mentioned, that weighting of decisional authority, I think that's a very interesting idea. I think going back to the ethical principles underlying surrogate decision making, things like substituted judgment. I think it's a spectrum, because as in the dementia world, you want to kind of encourage that engagement, that dyadic collaboration early on, when people can still contribute to decision making, but then there is the trajectory of decline. So I think it's dynamic. My personal perspective is that it's not going to be static over time. And I think it's larger than just like at this one point in time. How do we capture that? But I'm interested to open it up for conversation, because I think it's a great point, great question.
I was thinking this might be a great opportunity to include the Lindstroms. Do you have anything to add? And I'm happy to summarize the question again for you.
Yeah, please restate the question.
Nicole, would you like to reframe it for family members or caregivers?
Sure, I'll give it a stab, and maybe I can even use it sort of kind of in a more case-based scenario. So I work commonly with older adults who have varying levels of cognitive impairment, functional impairment, and they involve a family member in their decision making. And sometimes the implications for the decision and what sort of has to be acted on once a decision is made actually is more impactful for the family member, meaning that they are the ones, and I'll use a really kind of, they are the ones who are having to pick up the medications or drive them for the follow-up, or, and this isn't even end of life. I'm, you know, a lot of the times I'm thinking about the sort of day-to-day decisions that they're making in the primary care setting, where the implications of the decision weigh both logistically heavy and but sometimes emotionally heavy on the caregiver. And how do we balance that when we're thinking about the kind of triadic decision making, knowing that, I mean, we are individuals and we want to you know, have our sort of individual autonomy, but we also exist in the unit, as you guys know, as a family, and the decisions are sometimes familial, not necessarily just individual. And how do we weigh this?
So yeah, we've recently been on that side of the equation as well, and but we see it on the parent-child side. So with my mother recently passed away, and for the past 5 years we were the primary caregivers there. I have 7 brothers and sisters who were very involved peripherally in that process, and so you know, we were day to day with my mother, and she would be able to express her desires and wishes to us. And then we would have to implement and carry those things out for her. And also having, you know, a profoundly disabled child in our home, it placed a lot of stress and burden on us to be at both ends of that spectrum. And so we would reach out at times to my brothers and sisters to try and help with that. Sometimes that worked, sometimes it didn't work, but I think that the resources around you are what you have to draw from. And so, you know, burden sharing and trying to have others involved in the decision so that they can help with those things is really important. And I think that that's the best way to balance or get to that balance in the end run, is to make sure that you include as much of the larger community, support community, as you can. I don't know if that answers the question or not, but hopefully, from our perspective.
Thank you so much, Robert. So we have another question from the audience from Jenny Spencer. So may I please ask you to, hey Jenny, say where you're speaking from and go ahead and ask your question.
Hi, I'm Jenny Spencer. I'm a postdoctoral fellow at the Center for Health Decision Sciences, the Harvard Center for Health Decision Sciences in Boston. And my question is, I guess, sort of gets to this point. I like the phrase burden sharing that you just mentioned, which is very often, and I'm thinking about this primarily on the pediatric side, but I think it's probably also true on the adult side, which is you have more than one person who is sort of involved in making these decisions, but we tend to just capture one parent in a survey or one caregiver when we do these kinds of surveys, and not maybe the full nuance of the whole family and the siblings perhaps who are involved. And so I'm just curious, especially when we're thinking about more quantitative measures, how we can sort of get at how complicated those familial relationships are.
I can, do you want to start, Eve, or you want me to start?
No, go ahead, Ellen, I'll go after.
I think we both have a lot to say on this topic. And I would say that the first thing, while we absolutely need to figure out how to quantify these things, to some extent, though I agree with Eve from her prior comment about, you know, you need something, you might not need the best measure. We just really don't know for most decisions what that spectrum is of who's involved in the decision making. So I think being careful as in both to get a better sense of these processes, doing some qualitative work and survey work to better understand who's involved and the spectrum, so that we can even, both from a research standpoint, but also from a clinical standpoint, we can ask people, you know, there's always someone behind the scenes, right? Like, you know, a grandma or a sibling or someone who has an opinion who may be kind of a silent stakeholder. But I think if we start asking about it more, is the place to start to know who is involved in this decision making and inviting those people to be there. I also think that recognizing directly for families that medical decision making may be occurring in a very different way than other large decisions in their families. And we did some qualitative work years ago that we didn't end up publishing, but where we asked people how medical decision making was different from other big decisions. Our example was buying a refrigerator or a car. And kind of for most of the families that we happened to be interviewing, they would say, well, the medical decisions, mom's in charge, and the refrigerator decision, dad's in charge. And so I think there are these differences, and we just need to figure out kind of how we figure out who's there at the table, and then how to measure it.
So I love the way you said it. So Jenny, this is exactly what we struggle with. I think that we have defaulted to primary caregiver because it's easy. So, you know, like so many things we do, it's like, that's pretty undisputed. There's somebody, but who else there is, it's so variable. And I think the way Ellen described it as who else is at the table, it's going to be different for different families, and it's going to be different at different, both in different contexts. And I really like that analogy of it's not always the same bunch of people at the table for the refrigerator purchase or the, you know, school decision than for medical decisions. And that's going to really vary, but it is critical for us to know who those people are at the table. And it's going to be different for, you know, getting a vaccination versus end of life care. Trying to figure out what we can do, again, with the sort of pragmatic approach of, is it enough to get the primary caregiver, or is it better to get more, and kind of where do we stop? Like, kind of what's the marginal benefit of, okay, we've got 2 people at the table, what if we get 3? We do have some research that shows that when we're trying to quantify what's going on, you know, 2 is better than 1. There usually is a second person at the table who might be playing a secondary role, or the 2 might be sharing. What do we get if we start looking at 3, 4, or 5? It's kind of a cost benefit of the effort it takes to capture that stuff versus how much reality we get from it. But I agree with you completely. Going beyond 1, I think we're at that point now. We can push it beyond the primary caregiver that we conceptualized in the past to at least get, you know, another person or another player who might be more than one person who's sort of sharing that secondary role.
Thank you so much, Ellen and Eve. Did anyone else want to add on to that? All right, so we have another question coming in from the audience. It's from Lisa Prosser. So may I please ask you to tell us where you're speaking from, and go ahead and take it away.
Hi, good morning, everyone. I'm Lisa Prosser from the University of Michigan, and thanks for a really excellent panel. One of the points that you highlighted during the recorded remarks was this question about how to weight the various family members, caregivers, other family members. If we are looking to try to create some type of composite metric, combined either quality of life, health-related quality of life, well-being. On the economic evaluation side, I'll say, you know, the approaches here are really rudimentary and emerging. So at best, what you typically see in an economic valuation would be simply adding in a single caregiver's utility or disutility into the economic evaluation and weighting those equally. But we suspect that that may not be right. And you can think about how if you have 5 family members and 1 patient, that the patient caregiver utilities could quickly outweigh the patient utilities. There has been one proposed framework, but really in the emerging category for thinking about how to potentially weight those. Could you comment on kind of what your thoughts are on the decision-making from the decision-making field and any proposed approaches and any ongoing work in that area?
Apparently not.
Area for future research. Note to junior colleagues.
Well, at Utah, we have the Utah Population Database, and this is some work that my mentor is actually involved in, Dr. Lee Ellington at the College of Nursing, who's a clinical psychologist, and she has partnered with Dr. Catherine Ornstein over at Mount Sinai, who works in this area. So I don't know if I mean, I'm pretty new to the area of big data and population data, but because for those of you who aren't familiar with the Utah Population Database, they allow for linkages over families. So Drs. Ellington and Ornstein have, with a group of investigators, have developed a data set looking at decedents over a period of, I would say 8 years, people who died between 1998 to 2016. And so we looked at 2 years before the patient died and 2 years after, and then linking the family members to each decedent, being able to map out the differences in during bereavement. So hypothesizing that caregivers are going to delay the health utilization, and then that peaks after when the decedent dies. And this U-shaped curve is a lot of the work that Dr. Ornstein does, just looking at Medicare data that spouses especially kind of tend to delay their health care, maybe the preventive visits and things like that. And then that comes back down the road. Maybe that approach might be one way to do it. Of course, like we don't know from just the population data who's actually providing care. And of course, there's limitations in the data set, but I think that's kind of interesting. And I know it doesn't really get into the complex modeling, which is way above my head, I would have to admit, but I think those structures are really an initial step to look at some of the complex potential spillover effects that patients' health states can affect. But I really would love to hear from Dr. Wittenberg, because I really enjoyed that piece of what you were talking about, and maybe you could talk more about that.
Sure, I can comment on this, but actually, when Lisa posed the question, I really had this urge because we have them here to, if it's not too much of putting you on the spot, Robert and Jerry Lynn, to speak from a family perspective on this. So tell me if I am putting you on the spot, but this question that we deal with empirically in research of, how do we weight the input from different people in a family? I mean, we can play around with the data for a long time and we can hypothesize what's going on, but if it's not too uncomfortable to talk about this directly, when you're making decisions as a family, you think about your child and you think about yourselves and you think about how everyone's affected, and implicitly there is a weighting that goes on. There has to be, and when I was taking care of my parents, when they were near their end of life, we did this. We thought about this. We didn't talk about it aloud, but we were making these decisions of how much caregiving is it going to be? You know, what happens like if our mother comes home and we are literally doing 24-hour care for the next 5 days versus leaving her in the hospital? And what would she want versus what can we literally handle? We were implicitly weighting everybody's outcomes, but we never really said it aloud. So I think we are doing this, and I think people do it and families do it. And if we had those numbers, it would be fabulous to put into our models. But I wonder if you two could speak on it, because I was so grateful that you brought that you shared your personal experience in a highly public setting. And I wanted to thank you for that, in addition to asking you to share more.
Okay.
I talked last time, so I'll let my wife talk this time.
Well,
oh, now I'm putting her on the spot.
Yeah.
There we go.
All right, I'll start. So I will say that I think the nature of the question is very different from which perspective you're looking at it. So as a child with my aging parents, I was more of an equal player. Even though I was the legally designated decision maker, I was still more of an equal player among all of the parties that were at the table. But the other direction, you know, with respect to our child, we're very much more in the role of the primary decision maker, and so as you're raising your children, you know, it's hard as parents to remember that when they become adults, their opinion starts to be more thoughtful and intelligent, and to therefore give it the weight that it probably deserves. So I don't know that looking toward our children, we properly weight their position at the table. But then looking the other direction toward our parents, again, we're sitting at the table with in a much more equal position to the rest of the support community, even though the impact of those decisions is going to more largely affect us as the primary caregivers. There were many times where you know, my opinion, my decision was overridden or decided around based on the opinion of the others sitting at the table. So it's an interesting question. I don't know that you can quantify it outside of anecdotal data. But it's truly one of the harder things to grasp in this decision-making process.
I would say on a more practical side, our children span quite a few years. Our oldest daughter is 30 and our youngest son is 5. And our youngest son, and some of the things we've had to deal with, he's had some medical issues also and had to deal with. I have noticed over the years that our primary care doctors have addressed our son and what he thinks way more often than it was with our daughter who's 30. They looked to me. But now I find that I see them asking our son Eli, well, what do you think? Do you understand what's happening here? And I feel like that's a good starting point in having, like he said, their weight at the table. And so for me, that I've seen that progress over these years. And I think that's a positive way to go. And I like that when we are making decisions with our younger son, with some of his things, that he feels like he's involved. Because it didn't seem like that was the case with my oldest daughter. And with regards to Spencer, there's so many moving parts that I feel like people who have medically fragile children or parents who need a lot of help, they do need to have a lot of people at the table to help them make those decisions. And it's not a bad thing. It's a good thing to have everybody there and try to come to a decision. And
but I would say in that regard, the people at the table are, for us, have not generally been family. they've been our medical support community, our doctors and therapists and whoever.
With regards to Spencer.
Yeah, with regards to
that's true.
Spencer, a little handicapped guy.
Yeah, with regards to aging parents, you've got to get other family members in there to help, like you said, share that burden. With Spencer, it's just been kind of us and our team that we have surrounded ourselves with, who we absolutely love them all. Couldn't do it without them. So hope that helped.
Thank you both so much. And on that positive note, just wanted to thank all of you for coming out today. Many thanks to the panelists. Thanks to the organizers, Jody and Devine. So we're now entering our break for 1 hour. There will be sessions to start at, I'm in Eastern Standard Time, so at 1 p.m. I did want to highlight one particular talk that I hope people can come out to. It's the Aware Actions to Work Toward Advancing Racial Equity, Anti-Racism workshop sponsored by SMDM Advocates for Equity, and that will start in 1 hour. Thank you all so much again. And for those of us on the East Coast, enjoy your lunch break. Take care.